Hello everybody, welcome to our first Red Cell Network sickle cell workshop. We've got a panel of 4 people here today to talk to you, but I'm hoping it's going to be really interactive and we're going to have lots of questions that you'll put in the chat and we'll go through. There'll be a short break and you can obviously go onto your table, back onto your tables and talk to the people you've met. But please do try and make this as interactive as possible and ask lots of questions. So on the panel today, we've got Dr. Sarah Trumpeter, who's a consultant haematologist and paediatrician, works here at UCLH. We've got Dr. Perla Eleftheriou, who's our consultant haematologist here at UCH as well. Mati Asante-Owusu, who is the sickle cell community matron based in Camden and Islington. And Ruth Anderson, who is our counselling psychologist, again here at UCH. And I'm Bernadette, sorry, I don't think I introduced myself. I'm the lead CNS here at UCH and education matron. So we're going to start off with Dr. Trumpeter, Sarah Trumpeter, presenting a transfusion case. And you can ask questions throughout and then we'll come back to them once she's finished. And they don't necessarily have to be related to this presentation. It can be anything transfusion or sickle related. But yeah, thank you, Sarah.
Thank you, and thank you for asking me to speak today, and hello and good afternoon everyone. Thank you for joining us on this sunny day. Now this was, not all things happen like this, but this is an example of when things don't go quite right, despite one's best efforts. So I can see the chat and I'm really happy for questions to be asked at any point during this short presentation, and hopefully it will get us thinking a bit more about difficulties that you can face when you're transfusing patients. Next, please. Thank you. So this is a story about a woman who's in a prime of her life, age 48. She's got homozygous sickle cell disease, and actually she's been reasonably well. She's had a lot of children, and she's not really been that unwell with it all. She's been living abroad. She's had a few transfusions in the past, but mostly to do with pregnancy. She's not had any of the serious events one often associates with sickle cell, other than in 2001, where there's some sort of history of going to intensive care and receiving plasma. Next, please. So other than that, in her past medical history, she's got avascular necrosis and had a hip replacement. So her joints aren't great, and her left shoulder in 2014, and she's got AVN also in her other hip and right shoulder. The reason she came to us was because she now had breast cancer, and she needed really to be in a place that could manage both her cancer and her sickle. And that's the kind of place that I work at, so I got to see her. She'd already had a course of chemotherapy and slightly fell apart, and they started giving her radiotherapy, for which I think her not that I understand too much about cancer, but isn't particularly sensitive to. It's not the treatment she should have been getting, and she was keen to get the treatment she should have been getting. So she came to UK for a second opinion. Next, please. So I took a good transfusion history because I like that sort of thing, and we sent off some extra blood tests. I knew she'd had a delayed hemolytic transfusion reaction in 2005, and I knew she had some antibodies known as JKB and anti-KEL. But when I saw her, I did some more tests, and we noted she had some other antibodies, anti-big C little e and anti-little s. We knew what kind of RH group she had, but she had a lot of variants. We can talk about those. And she had a 1-unit transfusion post-breast operation with no transfusion reaction in 2016. So I was feeling worried, but I was also feeling moderately happy that perhaps if you matched her properly, she wouldn't have a transfusion reaction. Next, please. So next, what happened is that we started to see her, and I think she had a very complex transfusion history, and the chemotherapy she was going to get wasn't too awful. It was a relative comment, of course. And I think on balance and discussion with the patient, we decided not to transfuse her up front and just to see how things went. And in fact, they went really well. So I was feeling terribly clever about making a good decision on, well, advising my patient correctly. Next slide. So next, unfortunately, it turns out she's got the BRCA mutation. So now they want to do a great big operation. And I think we've got to the stage now that with a major surgery and having been all right with a previous transfusion, the balance had shifted somewhat. And we decided that the safest thing in this setting was to have a transfusion pre-operatively. Next, please. So in all my brilliance, I decided that the automated exchange would be the right course of action, but I was still feeling fairly nervous given the transfusion history. It's all abroad, so you never quite know what happens. And so we opted to give her some treatment that we know prevents a lot of transfusion reactions, which is immunoglobulin and methylprednisolone. I'd written extensively to the blood service to discuss her case with lots of clinical information. And I consented her, told her she might have a transfusion reaction, discussed it all, and she has a very nice automated exchange and is very well. Next. So she has her operation, and I go and review her post-operatively, and I get told by the nurses she's got hematuria. So a lot of people are saying they can't see this. I wonder if they're on the wrong browser and whether they're, because I think you said it only works on Chrome and the other one. Anyhow, so she has her operations and they say hematuria. So I'm hoping this really is hematuria and I can blame it on the surgeon because they've damaged the ureter. But in fact, I can't blame it on the surgeon. I can only blame it on the blood and myself. It's hemoglobinuria because when we look at the urine, which supposedly has blood in, it doesn't have blood in, so it's hemoglobinuria, which means that the blood is being broken up in the circulation and she's got intravascular hemolysis, which is a total disaster. Next, please. So we did a whole bunch of tests, and actually when we looked at the urine, we could tell that the only blood that was being destroyed was the transfused blood, which makes it a delayed hemolytic transfusion reaction. Which is better than other transfusion reactions, but still isn't a great reaction to have. So we look back at what she'd been given for the initial transfusion. Next, please. And we knew she had anti-big C and little e and a D variant, but they'd actually given her little e, which is, I thought was an odd choice, although they sort of justified it by saying it doesn't usually cause hemolysis. I'm fairly clear it did on this occasion. Next, please. So why is all of this so worrying? Next. It's so worrying because she's about to hemolyse. She's sitting up and talking to me saying she feels great, but she's about to hemolyse all the blood that I've given her, and I've taken out all her own blood. So she's only got 12% of her own blood with a hemoglobin of 100. So that means only 12 grams per litre is going to remain in about 24 hours. So she's going to get profoundly anemic. Next slide, please. So we sent it off to RCI, that's red cell immunohematology. That's where they do more fancy tests in the blood service. And we gave her some slightly different blood. And every time she got hit, went near to 40 grams per litre, we gave her a unit of blood. Next, please. So we did lots of things as well. They're not all terribly evidence-based. ITU is the place for someone like this to go because you want really close observation and sequential frequent blood tests and urine observation. We tried to immunosuppress her some more. We gave her some iron, B12 and folate because what we need to do is increase the chance, well, encourage her to repopulate her bone marrow with her own sickle cells, the stuff we were trying to get rid of in the first place, because we can't let her die of anemia. She's going to lose all the blood we've given her. She may well hemolyse everything else we give her. So we need her to start making blood. So we kind of try and suppress the reaction and at the same time give her all the ingredients for her to make blood. Next. And these are some of the blood results. So in bright blue, you can see the hemoglobin, so it troughs, and every time it peaks, it drops down again, because actually she hemolyzed everything we gave her. The little red arrows are transfusions. The bilirubin went up, as you'd expect, with intravascular hemolysis, and the sickle percentage dropped initially with the exchange, and then went all the way up as she reconstitutes her circulation with her own sickle cells. Next, please. And if you can see on this slide, the hemoglobinuria in the main urine bag, but what's really delightful, and it's like the happiest slide I've ever taken, a photograph I've ever taken, is that there's clear yellow looking urine in the catheter tube and in the 1 hourly collector. So she is getting better, and that's when the hemolysis is settling. Next. Yeah, and next is fine. So now this is something to discuss. She's come back to me 2 years later. It was quite interesting during the ITU stay. She said, "It's too cold here, I want to go to the ward, and why are you looking so worried?" But she now wants a hip replacement, which is an interesting discussion. And she wants hydroxy. I think she should probably have hydroxycarbamide. And well, we should discuss it. So I'm just quite interested what people who are watching today, what their thoughts are regarding either or both of these issues. So over to the audience. Has anyone got any thoughts on starting this lady on hydroxycarbamide and why I might want to do it? Bernadette, you know.
Thank you, Sarah.
What do you reckon,
anybody's got questions and views? I don't think she should have her hip done, and she should definitely take hydroxycarbamide.
It's a hard one, isn't it?
How old did you say she was?
48. She's a bit older than that now.
Yeah. So it was stressful. I remember hearing about it.
Yeah. Matty, what do you reckon? What would you do?
I would do exactly as Bernadette said, and then I'd probably have a large drink afterwards in the evening.
So, Pearlie, you've done something like this, haven't you? You've managed someone with hideous transfusion history through a hip replacement. Although I seem to on the day of the operation, it turned out that I was on call, thank you. But it's not impossible to manage someone with a hideous transfusion history through a hip replacement, but it's a fairly high risk event. Remind us what you did, Perla.
So, Sarah, this case is really very highlights one of the most dreadful, isn't it, as you say, complications in sickle cell disease. And indeed, I mean, those cases are always create anxiety amongst the team, as well as, you know, to the patient. So I think there could be several things here to say. So in terms of your last slide, you were asking whether there is an indication for hydroxyurea. Absolutely, there is an indication for sickle modifying treatment, regardless of the operation, and whether the operation is going to go ahead or not, because you want to you know, modify the sickle cell disease. You want to reduce the risk of crisis and of complications. You want to do something about it. So hydroxyurea, as well as novel treatments, which are on, you know, let's say she was not very keen to go on hydroxyurea.
She's Arab, so she's got a very high hemoglobin, so she wouldn't be suitable for GBT.
Yeah. So like crizanlizumab, and there will be Mara, and there will be, so if for the future there will be, and it's exactly good place here to mention that there are exciting novel treatments, isn't it, in the pipeline for patients like this one. But at the moment, yes, I mean, what is available and what would be standard of care would be hydroxyurea. Now, in the case of how are you going to optimize her prior to the surgery? I mean, if it really has to go ahead, because obviously the first thing is to try and avoid this from happening, avoid an intervention like this, because whatever you do, the risks will be very high. But how can you minimize the risks? So you gave her IVIG and steroids preemptively, yes, the first time, and she's still hemolyzed, but did I get that right? That so could we do better? That's the question with
no,
with a transfusion.
No,
with
because
the transfusion. No, right.
no,
So
and I'll
could
tell
we
you
have?
why. She'd need R
Yeah,
double prime,
right.
which and then you have to match for the JSB, and already R double prime as the RH group is like 0.0003% of the population, so that we really don't have blood for this woman
Right.
that would match according to that.
Right. So
those categories.
Right. Even if we mobilized donors, to get some unity in preemptively, it will still be impossible, really. Yeah.
She was quite well matched, actually, and she didn't form a new antibody. And I could never. And all the extra units I gave her additional hemoglobinuria. So I think she just hemolyzes everything. And I couldn't quite put my finger on what we were doing wrong. And it was only her. Only the donor blood, so it wasn't hyperhemolysis.
You don't think it was hyperhemolysis?
No, she had no S in her urine at all, and she.
But then it's very. Yeah, but then of course the difficulty, as you very well know, is that it's very difficult to always, rely on the urine HPLC, and whether there were very small amounts of fecal hemoglobin.
She had frank hemoglobinuria, and even as her S percentage went up, and she still had frank hemoglobinuria, there was still no S in the urine at all. So I think probably, and even then we'd given her IVIG and steroids
twice. Yeah. So the other thing that I wanted to mention is that whether this was a severe DHTR or hyperhemolysis, whatever one wants to call it, the management, because of how she, because of the disease and how she went last time, would be more or less, similar. So I mean. Or majority of you might know that NHS England has recently approved the use of A, eculizumab for acute hemolysis, and B, rituximab for prevention of severe DHTR or hyperhemolysis. So one thought here would be, so option number one would be IVIG and steroids prior, have the right blood as much as we can, match it to her requirement, standby, and have eculizumab in hand to give on should she hemolyzed, should she needed a transfusion perioperatively. And option number two would be to discuss the use of rituximab preemptively.
Yeah, I think it's really tricky. I think the bottom line is I would not want to transfuse her unless I had zero other chance. Absolutely. I don't want her to she's getting old for sickle certainly, and this was about 4 years ago. It was in August, and you were all on holiday, and you left me with this. Thank you. Cheers, mate.
Very tricky.
I was there.
But I think you do need to discuss those options with her, isn't it, Sarah?
Yeah, it's a really hard one. I did start her on hydroxyurea.
Yeah,
and she's done well, but she's quite crippled by her hip replacement. But I told her to have a little bit more of a think about it.
Yeah. Ideally, she should avoid.
I am worried that even if we don't give her blood, she'll get a chest crisis, and then she's a chunky lady. She's not young. It's a massive operation, a hip replacement. It's high risk even if you can use blood. So
absolutely,
in someone like her. Anyhow, thank you very much for contributing.
Great.
So I'm just thinking, so obviously there's a lack of understanding about the severity, like you were saying, I just want to get off of ITU and go to the ward, and just being a bit reluctant. And I'm wondering if Ruth and Matty have anything to think, what work could be done with her on more of a psychosocial point of view to make her understand, so she's not just doing it because I've got a bad hip pain. She really knows how to kind of understand that and work with that information about how severe it is. Ruth or Matty?
I think for me, obviously with her kids would be a priority and a driving force. And it would be, I suppose, looking when she went home to see what support, what help she's got at home, to see if there was some help that we could put in to actually help her manage her family, and probably to save her maybe doing as much work.
Yeah, and I was just going to say, I guess it's about that exploration with her, as Sarah and the team have been doing, around, you know, why she might want to do that, why she might not want to do that, and all the different factors involved within that. So that, I guess, you know, she's being listened to in terms of why it might feel particularly important for her to go ahead with this, but then that's balanced with everything else. So I guess it's that process of collaboration and conversation, really, to see where she's coming from with it.
I think it's a recurrent problem, isn't it? We've seen it many times, and we're going to see it many times in the future. Patients not realizing the severity of their condition, especially when it comes to situations, because, I mean, they are all used to come to the hospital for acute, you know, situations.
Do you think it's not realizing? Or
they
do you think...
I don't know about your patient in particular, Sarah, but a lot of patients don't, I think they don't realize that. They think crisis the doctors will make me better and I'll go home. And I mean, you know, we've got a couple with history of significant life-threatening hyperhemolysis who still don't, but, you know, don't realize the severity of it. But you're right, that is it always not realizing it, or is it being in denial, or it's very difficult. But as Ruth said, it takes a lot of back and forth discussions, and not just with the hematologist, but I think the clinical psychologist's input is really of paramount significance in this kind of discussions.
And also patients won't always weigh up things in the way we do. We will weigh things up.
Yeah, absolutely.
And, you know, we think life at all costs, you know, that's life, you know, that's number one. Yeah. Whereas actually some patients may balance things slightly differently. And so, I mean, I know one of the patients that you're sort of alluding to, you know, actually wants a child above anything. And is prepared to put herself at risk, that is making us all a bit sweaty, quite honestly, and nervous over, you know, we're all looking at our on-call rota, just panicking about which of us have to be on call as she gets more pregnant, because we're so worried about her. But it means everything to her to be able to do that. So I think, and I think the other thing is people try and normalize very difficult situations and underplay them, because actually the reality of how difficult and the enormity of what they're facing is just so huge that by minimizing those events in their lives, it becomes easier to sort of cognitively get your head around. I don't know if Ruth would agree with that.
I guess people have different ways of trying to cope with what's going on and to cope with difficulties. I guess there's something you're saying about looking at somebody as the whole person. So looking at them in relation to their condition, but also what all of their hopes and plans are, you know, what their values are, what they would like for themselves right now and in the future. Because I guess everyone is so much more than what they might present with to the hospital. You know, as you say, they have a life, a rich life, and want to live that life like anyone else might.
So just final point, a lot of our patients don't want to appear to their mates, to their family members, as, you know, being debilitated by their disease. And that's one of the reasons they might occasionally be, you know, blocking almost, you know, what is going on with them.
I guess that might often be because of the responses they might have received in relation to their condition. So they might have experienced stigma or discrimination or lack of belief or all kinds of things in relation to their condition. So a sense of needing to hide it in some way or hide the pain might happen.
Indeed. Are there any questions from the audience at all that we haven't picked?
No, nothing.
Okay.
Nothing yet. So we can obviously come back if anything pops up. It doesn't have to be particularly patient-based. It could be more about the transfusion aspect of it, if you've got questions about that. So we'll come back around to that if you have anything. And please do, even if it's not a question, even if it's a comment, just kind of pop it in the Q&A section, and we'll pick it up from there. Thank you, Sarah. That was great. So next, Ruth is going to go through a presentation, a few slides, and then we'll invite the panel back up when she's finished, and hopefully have a few more questions. Thank you, Ruth.
Thanks. So I'm going to go through my presentation on offering psychological support to somebody with sickle cell disease. And so I'm going to talk about my work as a psychologist with someone with sickle cell. But before I do so, I thought it might be helpful to look a bit more broadly at some of the key challenges that someone with sickle cell might face, possible psychological difficulties, and some possible positive outcomes associated with psychological support. So just to turn, first of all, to some of the key challenges. And I've got this word cloud here because I thought it was quite a powerful representation of some of these challenges. And one of the words that stands out here is pain. And so, of course, there's susceptibility to sickle cell crises and experience of pain. And also, there can be serious and multiple medical and cognitive complications associated with the condition, and ongoing invasive and unpleasant treatments that might be needed. And there can be a lot of hospital visits, and that can result in an experience of trauma associated with those visits. And other words here speak to the unpredictability of it. So not knowing when a crisis might occur and the interruption that might occur to everyday life and the effect that that might have, for example, on being at school, being at work, and also on being able to interact with others and to attend important events with others. And other central words here are around stigma and disbelief and discrimination. And I'm going to focus a bit more specifically on that in a moment. So just to quickly look at some of the psychological difficulties that might be associated with having sickle cell. So, we've spoken about health-related reduced quality of life. There may be some neurocognitive impairment. There could well be anxiety, and that anxiety might then be associated with having more crises. And also depression, which is associated with increased distress and pain intensity. I've also put down something around internalized stigma, about how we might feel about ourselves, how perhaps there might be a sense of being devalued. And also possible social isolation if we're not able to share in all the events with others that we might want to. And then just to consider a couple of positive outcomes that might be associated with having some psychological support. So having that opportunity might lead to developing some increased coping and self-management strategies for the pain. It could perhaps ultimately end up in some reduced levels of pain medication or reduced frequency of crises or of hospital admissions. And there's also something about talking about experience and then perhaps that resulting in reduced tension and conflict and improved communication with others. So I just want to turn now and talk about somebody in particular that I work with at the moment. So I'm going to give a sort of presentation about my work with this individual. And I'm using a psychological model called the Power, Threat, Meaning framework here to think about this person. And this model, it's an alternative to more traditional models based on psychiatric diagnosis. And it applies not just to people who've been in contact with physical or mental health services, but it applies to all of us. And it can be used to help us to create more hopeful narratives about our lives and the difficulties we have faced or might still be facing, instead of seeing ourselves as in some way blameworthy, deficient, or mentally ill. And so this framework, it integrates different evidence about the kinds of threat that misuse of power pose to us, and the ways in which we've learnt to respond to those threats. And the approach of this framework can be summarised in these 4 questions here that can apply to individuals or families or groups. So there's something first about what's happened to you, how has power operated, or how is power operating in your life? And then how did it affect you? What kind of threats does this pose to you? What sense did you make of it? What is the meaning of these different experiences to you? What did you have to do to survive? What kinds of threat response are you currently using? And there's an important further question which is needed to help us think about the skills and resources people might have and how they might pull that together into their personal narrative. So what are the individual's strengths? You know, what access to resources do they have? And what is their story about their experience? So I'm going to talk about somebody that I've been working with. I'm going to make it anonymous. I'm going to call him Louis. And I'm going to have a think about these different questions in relation to them. And so in relation to that first question, how might power be operating in his life? And I've come up with sort of 3 different headings. There's something around biological power. That is that Louis was born with sickle cell, and as a result, he experiences acute and chronic pain and has organ damage. And then in terms of interpersonal power, that is the power operating through relationships in his life. Perhaps one important thing to be aware of is that his mother left when he was 4, and he was brought up by his father as an only child. And in a combination, perhaps, of interpersonal and institutional power, Louis has not always received the care that he's needed for his sickle cell. So he's told me that he's not always received pain relief quickly enough. And at one point, quite recently, he nearly didn't receive urgent surgery in relation to a life-threatening complication of his sickle cell. And so just to take a detour, just away from Louis, to look a bit more broadly at this area of interpersonal and institutional power, because in my experience, it's an important one when talking with people with sickle cell. And so I just pulled up a few headlines from a recent peer review of services for people with hemoglobin disorders, which flags that improvements have been made, but services for this group of patients do remain underdeveloped and of variable quality. And people with sickle cell often report delayed or inadequate pain management by non-specialist teams in acute episodes. And importantly, this review also states that the Black Lives Matter movement has highlighted many deep inequities within society in the lived experiences of individuals. And it's important that different services are aware of what might be operating and of changes that might be required to ensure that healthcare provision is anti-racist and responsive to the needs of this group of people. And I just recently, I read this article that was published in the New England Journal of Medicine, an article called "When Actions Speak Louder Than Words: Racism and Sickle Cell Disease." And this article, I mean, it's based on people's experiences in the US, but I think it could also be transferred across to people's experiences in the UK. That often people with sickle cell might be combating unbearable pain and also stigma and discrimination within different settings. And that people might be dismissed while trying to seek medical care, or be described as drug seekers, or accused of feigning their pain, which might result in inadequate treatment and more suffering. And just to flag the effects of stigma and discrimination and racism on physical well-being and care seeking, it's important to reflect the effects that it has on physical as well as psychological well-being. It can lead to greater pain and pain interference with sleep and daily activities. And people have reported treating pain at home or waiting until the pain becomes unbearable before seeking care as a result of stigmatizing experiences. So I'm going to go back to Louis now, and I'm going to talk a bit more about him. So I've already spoken a little bit about how power might be operating in his life. And now to turn to the kinds of threats that this might pose to him. I've already spoken about bodily threats in terms of pain and damage to organs. And it's also too important to consider what the impact might have been of being left by his mother and not receiving as much emotional care as he might have needed when he was a child. And there's also this sense of being devalued that I spoke about earlier. So both due to his mother leaving and the lack of care that he sometimes had in a healthcare setting and other settings. So what meaning might Louis have attached to what's happened to him? And sometimes these meanings have left Louis feeling even worse, for example, feeling unsafe and afraid, not feeling good enough, and feeling a profound sense of injustice. And what kinds of threat response have we identified that he might currently be using? And these are sometimes called symptoms, but it's important to consider that these responses are there for a good reason, and some may have been necessary survival strategies. So Louis talked about experiencing anxiety, about being depressed, but also at other times, this kind of emotional numbing. So perhaps locking off his feelings and not going there. There was also something around him self-silencing and not feeling able to express certain needs that he had, and having quite a conflicted image of himself. And also, he very much took on caring roles and sought care and attachments from others. So now to turn to his strengths or access to power resources. And Louis has an abundance of these. He has a caring and supportive family and friends. He has connections with other people with sickle cell where he can talk about his experience. He has a fulfilling career that means a lot to him. He has a strong set of values and a sense of purpose for his life and a strong sense of social responsibility that means that he readily volunteers for things. He's physically fit. He tries to look after his body and his mind. He expresses his feelings through music, and that gives him a real outlet for some things which can be hard for him to express. And he has a lot of qualities. He's intelligent and resourceful. He's determined. He's conscientious, and he's very kind. He's a very kind person. So I wanted to turn and just think about some of the ways of working for me with him, what kind of things I might be doing, which can also be extended to anyone working in this setting. I think a lot of these can be extended. So there's something about validating and clarifying his experience, and this was particularly important during a time that he was on the ward. And he was in a lot of pain, and he was trying to get some urgent surgery. So both on the ward and after he was discharged, to really be able to validate his experience and clarify what had happened for him. And then there's something about him being able to access and express some of his feelings, and also to recognize and validate different parts of his experience and different parts of himself. So the part of him that feels very strong and resourceful, perhaps there's another part that can feel scared and of little value. And then there's something around building on the strengths and resources that he already has. So looking at self-care. And also for him, a priority was thinking about how to find and maintain an intimate relationship with somebody, which might provide him and them with some further emotional support and validation. So that's something around how I, as a psychologist, might consider working or have been working with him. But there's, as I've said, there's also something around ways of working as a team, that idea that psychology and all this kind of stuff is for everyone, and that a psychologically informed model of care is not just for people who are very severely distressed, and it does not always need to be offered by a specialist practitioner. So how might we all support somebody who has different challenges and different experiences? So I thought I do have some further slides which look at ways of possibly working as a team or as an individual. But perhaps I don't know if I should stop there and see if there's any questions or any suggestions on supporting someone, or I can continue through the rest.
So I'm happy to continue through, but we've had, I was just asking people what kind of threat responses do they see in their patients. So maybe people can kind of do that on the chat. But Hayley's also commented, how do we deal with or challenge stigma within communities when the parent views affect how the child feels about their diagnosis? For example, I mean, this might maybe wait till the end. For example, I have a family where mum wants to keep the diagnosis a secret, which is her right, but I wouldn't want the child to feel like they should be ashamed of having sickle cell.
Mm-hmm.
So,
well, should we save that? Do you want to save that for the end, for the general discussion?
See if anybody's got any other suggestions, but there's no other comments. So if you carry on, and then Hayley will definitely come back to that one. And if people can have a think about other things.
Yes, okay, well, let me just carry on a little bit and then allow some time for questions and observations. So I just wanted to first of all think about the role of patient as teacher within this. So I've got a quote here from a qualitative study that was done with young people with sickle cell. And so this person, Faith, said, you get a basic knowledge of it from just living. I know how to start my own IV. I know how to take my own blood pressure. I know what hemoglobin means. I know what my counts are, ferritin levels. I know all these different terminologies from experience, because you have to know in order to keep your health together. And, you know, I'm aware that this isn't the case across the board, but in my experience, many people with sickle cell develop in-depth personalized knowledge about their bodies, about the limits of their bodies, and knowledge about which specific therapeutic or clinical practices and medications work for their individual bodies. So there's something about the patient being listened to and being seen as an expert on their condition and on themselves, living with that condition. And then there's just something about the invisibility of symptoms and sometimes the lack of knowledge among some non-specialist staff can make it harder for people with sickle cell to make themselves heard. So people reported that they're used to being in pain and they practice certain techniques, such as breathing techniques, to help calm them down. But that might mean that to an observer, it might not seem that they are in a great deal of pain. And people also reported, as we were speaking about earlier, keeping the pain to themselves in their everyday lives by hiding or trying to control it to protect onlookers from becoming alarmed. And as a result, even when they were in severe pain, they might not be exhibiting signs of pain that others might expect from them. So I think maybe it's important to bear in mind that what we can see is not necessarily somebody's experience within themselves. And then there's something around anti-racist practice. And I've got this quote here: in a racist society, it's not enough to be non-racist, we must be anti-racist. And how might we begin to go about that? And I've just put a few things there. I put a resource list there with a link, and also an idea of perspective taking. So trying to put ourselves into somebody else's position and imagine, you know, if I spent a day as a sickle cell patient in this hospital, I could experience this or that, and I might feel or think this or that in relation to that. And I just wanted to finish the presentation really on something on strengthening the therapeutic relationship and the importance of the therapeutic relationship, whether that's the relationship that I might try and develop with somebody, or the relationship that any of you might try and develop with somebody, and that core idea that patient-centered care involves a collaborative and warm relationship between patients and health professionals, which of course can be difficult in a very sort of task-centered setting. You know, it is an extremely challenging ask at times. So I think there's something about being professional and being human at the same time. So taking time and listening and responsiveness and respect, trying to relate as equals, empathy and compassion, and genuineness or some level of transparency as well. And just to finish, I'm just finishing on this slide around active listening. And I've got a quote here, which is, because if you listen to the patient and give them respect, what you're actually doing is helping that person to take responsibility for their own health. They're also in control of the healing process and are involved somehow. So I am ending on the active listening idea. So that's it. That's the end of my presentation there. So it would be great to have some questions and discussions, perhaps.
Thank you, Ruth. That was good. That was great. Just wait for the other panel members to come back up. But just for me, it's obviously we see stigma with our patients every day, and you've talked about racism, and there's a question in the chat as well. Why do you think, or why do we all think there's still so much stigma around sickle cell? Is it purely racism? Is it, what do we think it is?
I think the actual sickle cell disease, you know, and the way it evolves over the years and the way it affects the patients has something to do with this as well. So you know that people who were born before hydroxyurea was even known or available, before we got to know what blood transfusion means in sickle cell disease and how it affects them. So they were all those patients, yes. So they ended up accumulating significant problems and developing problems around opioid tolerance and addiction, a lot of them. So I don't think, you know, if I understood your question right, Bernadette, I think it's not just a race issue. I think it is the misconception from the healthcare professionals' point of view about these patients, which stems from their actual disease and all the problems they've accumulated throughout their lives. I think that plays a big, you know, a huge role in how I see them.
I think it's very difficult to disentangle the race issue. I don't think it's not there. I think it very much is there.
It is
I think the patients are heavily stigmatized for their disorder. I think we don't have good treatments for pain, and we have undertreated patients for generations. Exactly. And we have left them with poorly controlled disease and putting them in and very, very low we have developed low expectations for them and them for themselves. And I think that really, really needs to change. When I'm seeing children in clinic, my expectation is they're going to school normally. And if they're not going to school normally, then something is wrong. And if it means that we are undermanaging their condition, or we're not supporting the family well enough so that they can help manage their health. And I think race does tie very much into that. I think there's expectations of children in certain environments from certain ethnicities that need to be challenged. I think patients face a lot of bias in the healthcare system, and it's not just our sickle patients. We know this from all sorts of patient settings. there are assumptions made that are just incorrect. You know, we talk about, for example, at the moment, everyone's talking about vaccine hesitancy, so putting the blame on the patient, and actually maybe it's vaccine ill-explanation. You know, where is, I mean, it's not helpful to lay blame, but it's helpful to understand where the difficulties are in delivering and supporting really good care of patients are, acknowledging where we're going wrong, acknowledging the challenges our patients face, and supporting change and addressing change. But I think they face an enormous amount of challenges, both within their community, within the healthcare profession, within society at large, and trying to support all of those is slightly outside our remit, but we can show by leadership how things could be done with appropriate resource, which of course none of us have.
So we summarizes the fact that this is not just race, it's race, but it's also all those factors that we've just elucidated on, and also the
so they tie in, Perla.
What they do, they are interlinked.
You say it's not race, Perla, or one might say it's not race. It's education.
No.
But if you look at the
no, Sarah. What I'm saying is that it is race, but it's other factors as well, which you have just explained and I have just explained.
But even they are to do with race. So if you look at the teaching and the inclusion of sickle in curricula, there is no haematology in paediatric training. There is no transfusion training in paediatric training. There's all sorts about cystic fibrosis, which is rarer.
Oh, no, absolutely. That is the race factor. Yeah. No, I agree.
So you can say it's lack of education, but why have they lack of... there's hardly any of us doing teaching.
It's a circle.
Well, it's a direct line. I think it's poor resources of teaching and education, and poor resources to support us and others doing really good work. A very small cohort of doctors and nurses and psychologists and other healthcare professionals who can deliver the training, the resources, and an underpriced tariff, so you can't deliver the care, and then patients get poor care, and then they do badly, and then we blame them for being on opiates.
Yeah, totally agree. So multifactorial, really, but with the race being in the center and driving forces. But what you just said, and what I had said just before you joined as well, is that the actual disease plays a role as well, and the fact that they were undertreated for generations before the sickle modified treatments came into the game and into the management of these patients, and they ended up developing huge opioid problems. And as Annette Blackmore put in the chat, another factor, which again is linked to the perhaps not only but definitely to a big part is linked, is a lack of knowledge and expertise among healthcare professionals.
Yeah, and I think we have to look at the history. We have to look at the history of it, and we have to look at why services have been badly funded, why treatments haven't been funded, and because that's been happening from the start, really, hasn't it? And whereas, as Sarah was saying, something like cystic fibrosis, there are far more treatments available, even though it's a less common condition, perhaps. So I guess it all, it's all very much intermingled and interconnected.
Yeah, absolutely.
And it's at the heart of it, I would say, really.
I'm just going to go back to about different people to know about a child's diagnosis, and and Sarah's already commented that it's not necessarily her right to, as the child has rights of their own, and just wondered what everybody's thoughts were about that.
I think it depends what they mean, isn't it, by not disclosing. So I guess if I'm a parent and my child has sickle cell disease and I don't want to tell my neighbor that they've got sickle cell disease, that's a different story, rather than not disclosing to healthcare professionals and schools. Then this becomes a safeguarding issue, isn't it? What does everyone else think?
So I was
the child.
Sorry, Reece, sorry.
Go ahead, sorry.
I was just going to say, I wonder if this is part of the thing that's playing into it, and it's not for anyone's fault of their own. We've just spoken about stigma and how that is, the stigma attached to a sickle cell affects everybody, affects all the patients. But the fact that it's not spoken about outside of that, the patient group or the us here today, is is potentially playing into it as well, isn't it? You know, every other advert on TV is for cancer or diabetes. People talk about it. It's there. Everybody knows about it, but we don't, you know, talk about sickle cell as readily. And whether that's us or whether that's the patients and the families, who knows? But that's just a thought.
Agree.
I was just going to say that I've spoken to different people who've I guess discussed that, about how their diagnosis was kept a secret. It wasn't something to be spoken about when they were younger, and how that might have impacted on them in terms of how they saw themselves, and also perhaps leading to perhaps a bit of a delay in kind of really understanding what it kind of meant for them to have that condition and live with that condition. So it can, I guess what I'm saying is it can have an impact if it is kind of kept a secret in that way.
And Matty, what do you think?
But if other people actually keep it within their community as well, because they don't want to discuss it, because it is a stigma in your community, because you've still got all the myths, oh, this person's going to die by the time they're 5 or they're 12 or they're 21. So I know culturally that a lot of people do not talk about this person having sickle cell or that person. They do try and hide it as well within the communities.
And I think Andrea, one of our pediatric hematologists as well, just put in the chat that it's not uncommon for parents not to disclose other diagnoses such as cancer. So one has to, you know, it depends on the case. There are parents who don't necessarily want to talk to people who are not relevant to the management of their child about the disease. So that doesn't always have to do with, you know, the fact that there is a stigma around sickle cell disease. But if we want to generalize it, then, you know, stigma around it is the main behind not talking about it.
Valerie makes an important point in the chat about somebody thinking they're protecting their child.
Yeah.
So, you know, from that stigma, you know, so they're acting from what they think, you know, is in the child's best interests. It's not straightforward. It's, you know, it's very complex.
I was just reading a message from Alice who says, I wonder if part of the difficulty is that the main presenting symptom reported by people with sickle cell is pain, and the nature of being in pain being subjective and complex, therefore difficult to communicate as the person experiencing it, and to assess in the healthcare professionals. Then there's a person reports, a judge, particularly through a lens which could be linked to their race and other social graces. And I think that just echoes kind of everything we've said. And
complaining of the whole pain issue and the painkiller issue is so laced with pejorative statements, comments, and judgments, and it makes it a very difficult one to address because it's subjective. It's very much there. The treatments are poor. The treatments are mind-altering, and I just think the whole pain issue is hugely complicated and really colours how patients are treated and approached. But I think I think it really comes back to absolutely appalling investment by the state into resourcing the care for these patients in really pragmatic ways, like nurses, doctors, psychologists, embedding training within curricula, within medical school, within nursing, within higher education, higher level education than that. And I just think without that and without the resources, and this is what I wrote when I wrote back to the inquiry, is that we can't do it. You know, this is all very well us 5 sitting here and with a very lovely audience, but you know, we need to sort of teach everyone in A&E and everyone in obstetrics and anyone in orthopedics who's seeing our patients with hip replacements. It's just a tide of NHS staff, and not just NHS staff, people in education, and we just can't deliver it. We can't deliver the training that's needed because we're under-resourced.
And it's not even NHS or wider UK, it's actually, you know, on an international level. But it is encouraging actually to see some steps ahead that or forward that EHA and other and WHO that taking forward. I mean, I've just actually before this educational platform, being in a meeting, discussing all those issues, and how, you know, they're now planning to do, you know, to increase the education courses and modules on the EHA platforms and other sort of, you know, international educational platforms. So, I mean, there is an increasing awareness of the needs, but it's just, you know, it's all very slow compared to other disorders and very underinvested compared to what it should be.
And it's important to note, I mean, in that peer review that I just mentioned, 2/3 of the services reviewed had insufficient or no access to psychology staff with appropriate competencies in care of people with haemoglobin disorders. That's a massive amount of services with no access to what might be needed.
Just another little point which really supports what we all just said. When I was composing the response to the SQL inquiry, I circulated amongst the colleagues, and it was an eye-opener actually for me to receive the following comment from one of the consultants who's been in the service for, you know, more than 25 years. They said, I actually had a deja vu, and it's exactly the same thing that you know, I wrote 25 years ago when, you know, there was another inquiry. So, and it seems that nothing much has changed since. So, you know, basically it just supports what we say, that things are moving, unfortunately, very slow.
And we had it just last year, or maybe 18 months ago. They said, oh, when we get a call to say, can you take this patient to ITU? Oh, it's just another sickle cell patient. Yeah, it's another sickle cell patient. They're just here for the painkillers, and then and this came from very senior staff. So it's worrying, and you know, there's more chat around it. I think, like Perla, you were saying, but we've had 2 huge tragedies in the sickle cell community this year alone, and part of me is that why we're talking about it more? Because everyone's like, oh goodness, we've neglected this population. Let's quickly do something, make it look like we're working hard, and in a few months it'll all kind of be forgotten again, because, you know, it's just, we must be seen to do something now. You know, cynical.
I think you're right, and I worry that it's like a lot of these things, they create a certain momentum, but unless there is significant investment and mandating of training, and then deliver. You see, if you mandate training, then they have to deliver it, because it's not mandated anywhere. No one has to deliver it, and therefore it isn't delivered, because people have not because they're horrible, nasty, racist people, but they have to train to do lumbar punctures, they have to train to do allergy, they have to train to do resus. So they've got a whole list of things they have to deliver to the nurses, doctors, junior doctors, trainees. They cross it off their list so that they don't get in trouble, but this appears nowhere. And when you approach the colleges, they say they can't, it's undeliverable because there's not enough of you to deliver it, so we can't mandate the training. But we'll never be able to deliver it, and therefore never will be able to mandate it unless we resource better. So the whole thing's totally circular, and it comes down to money and the will of government.
And priorities.
And very well the APBG listening to us, but they've done nothing either. You know, they've delivered, they haven't delivered.
Everybody knows that it's the same situation, and everybody knows what needs to be done. It just needs some action, money and action now, because we're just saying the same thing. As Perla said, somebody said the same thing as her 25 years ago. So it's like it's action that's needed now, because everybody's just saying the same thing.
And those 2 poor gentlemen who died, I mean, it's happening the whole time. That's just the ones that got into the press. There's tragedies, I'm sure, every month. I can think of situations with patients that have passed away where
and also a tragedy is not just death. I mean, you know, a debilitating complication, a stroke, or you know, near misses. Those are tragedies. You know. Anyway, yes, I think that's a very interesting discussion. I just had one last question for Ruth, please. Ruth, what's your sort of experience with the uptake of sickle cell patients in terms of psychological input? I mean, by and large, are they, I mean, from my point of view, when I see them in clinic, I think by and large they are receptive to the psychology input, but...
Well, absolutely. I think the vast majority of the people I work with are people with sickle cell. And with a lot of people, I've been working with them for a little while, and I think we've developed quite a good relationship, and that there's certainly people are very receptive to receiving this kind of support and to talking through what might be going on, and crucially thinking about how they might begin to improve things, you know, how they might draw on their strengths and resources, and how, you know, they might begin to move forward in slightly different ways. So yeah, absolutely, and I'm sure I could fill double the clinic space, triple the clinic
very
space.
Encouraging.
I had, you know, if only there was more, I guess, fund allotted to it. I'm sure plenty of people would welcome the opportunity for this kind of thing.
Yeah.
Sorry, I have a question. The threat responses you were talking about, and you mentioned things like anxiety,
depression, lots of different things, you know, self-silencing and everything. Do you have different levels of threat response? So, you know, on a day-to-day basis, this is how I live, but actually then when I'm unwell, I'm in acute painful episode, I'm in A&E. They can have a different threat response, because I'm doing another piece of work with some patients, and two patients, one has said, you know, when I'm not well, I just want to sit there in silence with a blanket, with my headphones on, I'm not in pain. And then another patient who said, I just want to get up and walk around, I can't sit down when I'm in pain. Are they kind of similar threat response, but on a kind of an acute?
Absolutely, I'm sure that we all have different coping mechanisms and threat responses in different situations. So, you know, when we feel really under threat, there might be certain things we do to try and help us get through that. And some of those things might appear, as I was saying to somebody else, that actually, you know, we're not in too severe a position, whereas actually that's what we're doing to help us in that present moment, whether it's trying to meditate or trying to move around the ward, perhaps. That might be a way that we're trying, as you say, to be with our pain and our distress. So yeah, absolutely, I think that would be a valid point.
Do you think with the pandemic situation and the fact that you've, as a consequence of that, you've moved to more virtual consultations, you will, you know, make things easier for patients to sort of, you know, keep in touch with you?
For some people.
Is it as valuable as a face-to-face kind of session?
Well, I guess I had some preconceptions before I started doing all this telephone and virtual work that perhaps it wouldn't be as valuable, that it would be a poor substitute for face-to-face. But I have to say, I think those beliefs have been challenged, because I think that we've been able to do some very valuable and deep work, either through the telephone or through video. And, you know, I think it has perhaps decreased the number of people who don't attend, because if you are in pain, or, you know, it can be difficult to go to the hospital, particularly if the hospital is somewhere that you don't associate with good things, you know. So, and to offer it, telephone can be good for some people, because perhaps they don't want to be seen, but they want to be heard. So I actually think it really, it's good to be able to offer different types of help, and it's something to continue going forward.
Great, thank you.
If there's no more questions for Ruth or around this subject, we'll move on to Perla's presentation, but keep talking in the messages or in the chat.
So I think it's an evolving conversation. It doesn't need to stop here. So
I'll hand over to Perla. Thank you.
Thank you.
And then after Perla and another discussion, we'll have a break.
Just waiting for the slides to come up. Right. All right. So thanks. So this is a complex case. Actually, next slide, please, Pete. Next slide, please. So this is a complex case of a female patient born in 1977 in Jamaica who was diagnosed with homozygous sickle cell disease at birth, so HBSS. She had a severe clinical phenotype with more than 3 vaso-occlusive crises a year, including recurrent episodes of acute chest syndromes and frequent hospital admissions early on in her life. And her VOCs were accompanied by acute and chronic hemolysis with often more than 20 grams per liter decline of her baseline hemoglobin, which led to ad hoc but frequent top-up red cell exchange transfusions, top-up or red cell exchange transfusions, really. So next slide, please. So on the right-hand corner of the table of the slide, you can see that little table, which summarizes that basically had baseline parameters. So baseline hemoglobin was in the range of 50 to 60 grams per liter. Reticulocytes about 30%, high LDH about 1,000, fetal hemoglobin 3 to 8%. At the age of 20, she suffered pulmonary embolism, and already in her early 20s, she was alloimmunized with multiple alloantibodies, which unfortunately rendered her extremely difficult to be transfused. At that time also, around the age of 20, she had a sleep study which revealed nocturnal desaturations, and from the age of 30, she had been on intermittent oxygen use at home, particularly at night and when she was active. Next slide. So her adherence to outpatients follow-up, generally speaking, was not optimal really over the years. And it was noted that she had transient pulmonary hypertension on the echocardiograms as an inpatient in the context of acute chest crisis, hypoxia, and acute and chronic hemolysis. But her usual once a year or once every couple of years echo screenings never demonstrated established pulmonary hypertension. The year 2008 was a particularly stormy one for her. And at the age of now 31, she had 5 ITU admissions that year and progressively worsening over the previous 2-3 years, fatigue and exertional breathlessness. Hydroxyurea was commenced that year in 2008 with great reluctancy from her point of view to take it. And in 2009, so the year after, she was admitted again with acute chest syndrome, significant hemolytic anemia, and had a blood transfusion, which unfortunately was followed by a delayed hemolytic transfusion reaction, despite cover with IVIG and steroids pre-transfusion. EPO was introduced, which she continued with post-discharge as well. So she recovered ultimately from the DHTR, from the hemolysis, and she continued on EPO and the hydroxyurea, but both with very erratic adherence, but nevertheless good tolerance at times when she was on that combination. And on that combination, the hemoglobin range was 60 to 70 grams per liter, so she had a relatively good response, and maximal achieved hemoglobin F response of about 19%. That was with roughly 15 to 20 milligrams per kilogram hydroxyurea. However, recurrent VOCs with acute hemolytic exacerbations continued, although with improved frequency and intensity. Next slide, please. So another acute chest syndrome in 2010, the echo at the time showed increased pulmonary pressures and tear jet velocity, but 2 weeks after, again, it was normalized. And a respiratory and cardiology review at the time, or around that time, showed that she now developed secondary restrictive lung disease with what we not that rarely see, a dynamic response and a tendency to develop pulmonary hypertension in the face of acute and chronic hemolysis and hypoxia. Further assessment in 2014 revealed that she had progressed to heart failure stage 3 and was now restricted indoors due to gradual decline in respiratory capacity over the last years. And she was on continuous home oxygen and wheelchair bound now. Next slide, please. Then in 2015, on the background of progressive restrictive lung disease and increasing pulmonary pressures with established now pulmonary hypertension, she continued demonstrating a dynamic nature with exacerbations of the pulmonary pressures in the presence of her acute crisis and acute hemolysis. Her baseline stats now were around 88–90%, and heart catheterization to look at the pulmonary hypertension side of things in more detail was very strongly recommended, but she didn't consent. She had a surgery in 2017, an emergency idialysis for small bowel obstruction, and actually did receive preoperatively 2 units of blood with IVIG and steroids without subsequent hemolysis, which was encouraging at the time. Next slide, please. At the age of 43, and having been lost to the follow-up again for 2 years, and having self-discontinued EPO and hydroxyurea, she presented with significant breathlessness, abdominal distension, edema, and a hemoglobin of 36 grams per liter, and acute kidney injury. So the diagnosis was decompensated right and left heart failure due to severe chronic hemolytic anemia and recurrent acute chest syndromes. And the kidney injury was likely secondary to the acute illness on the background of progressive sickle nephropathy. Yeah, she was treated at that time with diuresis and NIV or ITU, and was transfused with IVIG and steroids, and again, without complications initially. But unfortunately, from the transfusion point of view, but unfortunately, her heart and kidney functions continued to deteriorate despite the above interventions, and sadly died. Next slide, please. So here you can see the significant variation of the hemoglobin of the last 5 years of her life, with the lowest levels being about 40 grams per liter at the times she had these acute hemolytic episodes in the context of a crisis, and also reaching levels of 70 grams per liter when she was stable and complied with hydroxyurea and EPO. Next slide, please. And what is very interesting here to see is a correlation between the peaks of the creatinine with the lowest levels of the hemoglobin at the time of acute hemolysis. So the hemoglobin was dipping down and the creatinine was going up, clearly indicating that the kidneys were under stress at the time of the acute hemolysis. But also it's interesting to note that over the years, especially in the last 2 years prior to this acute presentation, which led to death, she had a progressive rise of the creatinine, so from 2018 onwards. So really, I think that's my last slide, if I'm not mistaken. This is the case of a very sad patient's history and outcome of, who had a very severe hemolytic sickle phenotype, who was unable to be transfused to modify the disease and was always hesitant to and not adherent to hydroxyurea, who developed detrimental complications, which unfortunately led to early mortality. That's it. Thank you. I'm happy to take your comments, questions.
Thank you, Perla. I brought this late. So
I find them so complex, and I understand
kind of I guess it's the basics of what I need to know as a nurse. You know, I haven't delved in and kind of found out more and more. But for me, it's a question of, and again, it's probably more on a psychosocial basis of what did we miss? You know, when she disappeared for those 2 years before she passed away, what did we miss? What could we have done differently to try and get engaged? And you know, and I'm sure it's the same in terms of in the medical side of things, of what could we do differently. But it's always a question with every patient that we lose. I know it is, but
I think the other question is acknowledging that some of our patients are near the end of life, and we should be backing off from driving them mad with medical interventions. And it's very difficult at the moment because we don't really understand the natural history of end-stage disease and sickle terribly well, because our patients used to die acutely rather than have a more slow, well, often quite aggressive decline is what we're seeing at the moment. And I don't think we understand it well enough, but we are starting to interact more with the palliative care team and have more sensible discussions about end-of-life care. And I can't help but, I mean, I know the patient you're talking about, and I know she was extremely young, but there was something end of life about her already, and I get the feeling that she knew that, and she wants to be left alone. And I think that sometimes we need to recognise that perhaps we're a bit too aggressive for some of our patients' taste at different points in their life, at certain points in their life, and we might need to just adjust how we or just think a bit more about how we support people with very significant end organ disease, because their lives are pretty wretched and they're often very symptomatic. And we're very often quite focused on trying to correct the numbers and the things that we can understand better, rather than perhaps their symptoms and where they are in life. And other things like that.
I think you're absolutely right, that we will be seeing more and more of situations like this, where people have accumulated irreversible damage to, you know, vital organs, and almost anything you would do would just, you know, prolong the suffering, really, you could argue. So the early involvement of palliative care is absolutely necessary, despite the young age of them. But another point here to highlight is that, I mean, this particular patient was born, you know, at the time of, again, similar to your patient, Sarah, and many other patients, it was born at the time when there was no understanding about matching blood, and, you know, so these obviously led to the development of those complications. So now, what do we learn? We learn that, which is always what we discuss, how we should start being, and I'm sure a lot of us are doing it already, more keen for early introduction of sickle modifying treatment, so as early as possible. And this is the only way that we can try and see less of those problems that we're seeing currently in this age group between 30 and 50. So early introduction of sickle modifying treatment, whether that's hydroxyurea or blood transfusions, or the novel treatments that are coming up in the, you know, to be available and accessible, hopefully. So yes, and psychological, yes, whether there was something that we could have done better, Bernadette. I mean, I know that, you know, that, and Ruth, I'm not sure whether it was Ruth or, there have been multiple attempts, and very kind of active attempts from all of us to engage the particular patient, to interact with psychology intensively, but there is a limit to what you can do about it. Completely declines this side of this you know, this kind of input, and that's why I've asked you, Ruth, earlier, whether this is something that you see, you know, whether you actually see relatively you know, a satisfactory uptake from the patient's point of view in terms of acceptance to be seen by the psychologist, or whether there is a problem. Because these patients' biggest problem, I think, was the lack of, you know, she would not consent to see regularly, at least, psychologists. So I think that played a role in the way things turned out.
I mean, I think it's up to the individual, and it's up to their, you know, set of circumstances, and as to whether they might want a psychologist or someone similar to come and speak with them. And of course, you know, some people do find it harder to engage than others, or to engage consistently for a whole host of reasons. And it's perhaps hard to have a consistent level of engagement. I guess there's also something around, well, you know, if somebody sees a psychologist, then what might they then talk about, and might they go into areas that they don't want to think about or discuss? So again, it's about how do we cope with threat? You know, one response is to I guess, shut down a bit, or to not want to look at certain aspects of our experience. So I guess you can't force it, is what I'm saying. You can offer it, but you can't force somebody to engage in it.
This particular patient that you spoke about, and her mother, I know, was a big part of her life, and I wonder if we'd engaged mum. I know mum, she came to all the appointments, she knew absolutely everything about her medical history, but if we'd have sat down and spoken to them a bit more about how things are going and that kind of stuff, and really tried that bit hard. I don't know, you always
yeah, it was a very difficult and strange almost relationship between mum and daughter, because, as you say, mum was accompanying her everywhere, and she was very involved and very caring, and yet the patient would at times
So don't talk to mum, don't tell her.
Ask actively us not to disclose information. So, you know, so it hasn't been, very straightforward in terms of, so it wasn't, I don't think it would have been a very straightforward case to involve both, but if we hadn't tried that, that's definitely, or, you know, that's a positive message, I guess, for everyone who's managing patients with sickle cell disease, how important it is to involve family in these discussions. I agree.
I don't know whose relationship with their mother is uncomplicated, but well done them.
Lovely. So is there any questions? Pop them in the chat quickly. If not, we'll move to have a short break. Don't think I've missed any. There's been a couple of comments from the previous session, but nothing so far for this one. So we'll go for a short break now, just 20 minutes. So we'll be back just before 5 o'clock.
See you later.
Thank you.